Hello, everyone. Thank you for joining us from various different time zones for today's learning session on urban health in migration contexts. My name is Karsten, and I supported the organization of this webinar in my function as an intern within the urban health workstream at the United Nations Human Settlements Program. And you already might know that today we have two insightful presentations ahead of us by two very distinguished speakers joining us from very different continents. But let me quickly take you through today's agenda. If everything worked out, you now see the agenda. We will have a few opening words by our session moderator, Jia, followed by a short introduction poll, and then the two 15-minute presentations of our speakers. Afterwards, we will have a 15-minute Q&A session, which you can make use of to clarify any questions that may have come up during the presentations, or to discuss any points of interest. Then, once more, we will have a short poll, and lastly, a few closing words, again by our moderator. What is left for me to share with you, the audience, is that this session will be recorded and later publicly made available. So if you want to have another look at it, that will be possible. I would also like for you to mute yourselves and when you're not speaking, and to write down all your questions until we'll be giving you the opportunity to pose them during the Q&A at the end of today's session. But before giving the word to our moderator, we, the organizers of today's event, are actually interested in you, our audience, and we would like to learn a few things about you. So let me share with you the polls. So first up, we would like to know which country are you joining us today from? And we also would like to know what your background is, or expertise in urban health and migration. And we also would like to know what your current understanding is of the interrelated issues of migration and urban health. And we have obviously people joining from Kenya. That's where the headquarters are of UN Habitat. People from Germany, Belgium, but also Indonesia, South Africa, USA, China, Netherlands. Currently, most people have an urban planning or development background, but we also have urban health professionals, people from governance, policy, or decision-making that joined us today, migration experts, and of course others. And the current understanding of the interrelated issues is rather low, I would say, 2.7. So let's see whether today's learning session will help improve that. And yeah, without further ado, I will hand over the word to our moderator, Jia Cong Ang, who is an program management officer here at UN Habitat with the Humanitarian Development Work Group. And Jia, thank you for joining us today. The word is for you now.
Thank you so much, Karsten, and thank you everyone from joining from such a wide distribution globally as well. It is my absolute pleasure to moderate the session today. This session is co-organized by the Urban Health Workstream and the Humanitarian Development Practices Workstream, which support UN Habitat's flagship program, Inclusive Cities, Enhancing the Positive Impact of Urban Migration. Migration lies at the heart of urbanization, with more than 258 million people living outside their countries of origin. And in mid-2023, the total number of forcibly displaced people was estimated to be 110 million by UNHCR. This is with nearly 50% of refugees worldwide being children under the age of 18. 60% of migrants And 80% of refugees and internally displaced persons are drawn to cities in search of safety, shelter, and housing, and increased access to basic services, livelihood opportunities, and better health conditions. Thus, people migrate to urban areas for various reasons, including escaping from conflict, environmental degradation, poverty, reaching out for more employment opportunities, and spatial inequalities. More recently, climate change has become a significant driver and root cause of forced displacement, making those forced to flee even more vulnerable due to extreme weather events like flooding, heat waves, droughts, and general environmental shocks. What all migrants share, however, regardless of their destinations and their places of origin, are the challenges of marginalization, stigmatization, and discrimination, often leading to severe implications for their health. These challenges extend to the poor living conditions, the inadequate housing, and the poor working conditions, along with the limited access that migrants have to healthcare services, despite already facing physical and mental health problems. Some of these health challenges include exposure to infectious diseases, malnutrition, inadequate prenatal care for mothers, and higher maternal mortality rates, including stress and trauma, amongst other things. And very often, the factors influencing these health challenges include the circumstances of their migration, the conditions of their host countries, and their socioeconomic statuses. And while we see that there are some countries who have picked up the slack, such as Australia, who are setting examples by welcoming migrants from Pacific Island states like Tuvalu, threatened by rising sea levels, regrettably, the global response, the most general response to this issue, is still insufficient, and it still requires so much more attention. So today, we embark on an insightful learning session, hoping to gain valuable insights from other countries that can guide us in crafting integrated and inclusive solutions to improve the health and well-being for all urban migrants and displaced individuals. I hope this introduction presents to you a background from which we will depart now. And with that, I'm very happy to introduce our first speaker for today. I would like to introduce Aruna Bhattacharya, PhD. Aruna is a medical anthropologist working in the domain of health systems research and public health. She uses her anthropological lens to study how power, hierarchy, and marginalization affect the access to public good. She currently is the lead of academics and research at the Indian Institute for Human Settlements in Bengaluru, India. Aruna's previous research has focused on drug-resistant tuberculosis in the slums of New Delhi and Mumbai, as well as child protection interventions in construction sites and railway stations, and access to nutrition programs among particularly vulnerable tribal groups. In recent times, Aruna has conducted an ethnographic study of COVID-19 health-seeking behavior in urban and peri-urban Bangalore. So as you can see, Aruna is best equipped today to provide us some insights into urban health issues. She will focus on the health challenges faced by internally displaced people and workers in the marginalized settings in India. Welcome, Aruna.
Thank you. So my time starts now. Very good morning, very good afternoon, and very good evening, because we're all joined by different people from different countries all over the globe. And I'm very glad to be part of this session today. And I hope it brings discussion and interaction at the end of our sessions. So what I'm going to talk about, as rightly mentioned by our moderator, that it be centering around urban health. However, I would like to also bring around the reasons of marginalization, how the lack of fairness and justice in our systems create marginalization, especially for the especially disenfranchised communities. So here I would bring case studies from marginalized setting, especially the urban slums of India, different cities, and they would be from different timelines and also different geographies. So it will also create an understanding that despite so much evidence, how come we are not able to see disparities and kind of bring things or put things together in our policies. So next slide, please. So today's presentation, the kind of categories that I've created, it will be three-pronged and in three layers. And systematically putting or philosophically putting, it is pretty much like a systems thinking, where there are things in parts and there are things we have to think together in interactions, and also in a dynamic fashion and in a process manner. And here these parts of migration, climate change, and health, and how it impacts health of urban population, especially from the context of migration and climate change. So yeah, moving to the next slide, please. So first part, as I mentioned, it would be around, I'd kind of bring things and start to build things like a snowballing, and I would like to see how everything and each and every prong is kind of interacting and having an effect on each other, rather on the health outcome, so to say. So migration is not a new phenomenon in India. People have moved across the length and breadth of the country for various reasons, including work. Today, India has a growing urban population, which contributes to about 63% of our GDP. But when we look at, I'm also trying to create things from a historical perspective, because oftentimes that also leaves a strong imprint, how we think and why we do what we do. So I would also bring a little bit of a partition stories, because these are all laden in politics. It's geopolitical. Also, there are also stories of decolonization. So the first kind of migration that we see, or I didn't say migration, sorry, it's like it kind of created exodus when we saw the country of Burma, now called Myanmar, kind of separated constitutionally from the British India in 1937. Then comes the India Pakistan getting separated, and also it is the independence of these two countries, and we saw an exodus of 17 million people. And it was also an interesting historical event where countries were separated on the basis of religion, following which we also see partition of Pakistan and formation of Bangladesh, which is 1971. And it is on the lines of language. And we see, of course, it is again from the recorded. There are also undocumented, and I'm sure this must have been more than what we kind of know. It's an estimate. We see 10 million people also, migrating and becoming, they're displaced. And also, oftentimes these displaced people are not having their rightful positions. So some of them also become, what very derogatorily put as migrants or refugees or, displaced people, and in different. So we have, when we look at the map of India today, from the eastern side and from the western side, we have stories. And now the assimilation of what we have in our country is also, stories of history, geography, politics, and of course, socioeconomic and cultural. So yeah, so that kind of creates a context. And then, when we talk about migration or rather exodus, I just mentioned about these are more kind of politically charged events. But then we also have, there are development projects that have also created displacement. So these are like outnumbered anything, which is like from the time of independence till now, there is an estimate about 40 million people being displaced for different development projects put together. Then coming here and now, we also saw a pandemic. Our recent pandemic, COVID-19 pandemic, creating lot of displacement. Some are to come back to the native place, or some to also look for new jobs, or getting pushed out of fear or things like that. So that was also a lot are undocumented, but I kind of put together like, how migrant laborers were put on train or put on buses. Those numbers are available, but then there are so many who actually walked and taken bicycle ride. And I'm sure, globally, those pictures are very, very poignant and very disturbing. So about 6 million people took trains. Like those are the estimates of migrant laborers or migrants, mostly informal workers taking train rides, because it was all done by, documented from Railway Ministry, and buses like 4 million people. So for moving forward, I would like to bring home what's happening right now, especially when we talk about, because when we think about migration and displacement, there is also a settlement happening somewhere, right? So this so these are we have to also put some figures and also understand the context right now. So in 2009, for the first time in human history, more people lived in the cities than villages. And then we see that, when we talk about so much of burden on the city, especially with the numbers, do we have the infrastructure or the fundamental drivers of improving quality of life? So those are the questions that I'll again link when we discuss health and sustainable development goals. So in 2011, 377 million people, that is 31% of our population, Indian population, lived in cities. Of this 65 million, 27% of the total urban population lived in extreme shelter of poverty, which are again, like usage of the term slum is again problematic, but this is, I'm quoting a statistics, so I'm using the term slums, but these are habitations which are not fit or not good quality. So the challenge is, this kind of challenge is not unique just to India, but also to countries like China, because also the population density and the mass migration, also the lure of work or employment in urban centers. So I'm also now quoting the latest, because our census happened in 2011 and it was supposed to take place in 2021, but due to pandemic, the census data is not available, and I don't think it is going to be done anytime soon, because 2024 we're going for the election, the country level election. So in absence of our data, absolute number, I'm kind of trying to pile up things from different sources. So there is this report that compiles migration in India on a periodic basis about the labor forces. It's called PLFS. So they kind of mentioned that about 28.9% is the migration rate, especially if you're looking at the labor forces. We can move ahead. So what I'm bringing next is the climate change. Of course, already we understand that this is the burden. And as we understand that climate change cannot be neglected, we already see the effect of climate change, especially in the marginalized sections, because they're already ill-equipped to handle the aftermath or the effect of it. So India records some of the highest numbers of internal displacement in the world every year, and most of that is triggered by disasters. So these are natural disasters. So exposure to intense and frequent hazards, and mostly rainfall and flood. So I have some, I think we can move to the next slide, which says that in 2022, the number of disaster displacement was at 2.5 million. So now this little slide that I have here, it has data from ActionAid's 2020 report, which says that by 2050, we will have displacement caused by disaster at 60 million. But if we look at the Paris Agreement of 2.2 degrees centigrade, 2.2 centigrade, then I think there is a little animation here. So if you move the cursor next, that box pops. It also talks about that is total. And then if we agree at that Paris Agreement, then it is at 22 million. So, still it's a huge difference. But likely we will not be able to at 2.2, but maybe 3.5. And that would also mean an estimated. And it's the Southeast Asia country, because they're also linked with the forces of environment and weather. So yeah, next slide, please. So when we look at impact of climate change on health, of course, things have a temporal in nature. Some would happen quickly, some would happen in a short-term, long-term effect. But it doesn't need for us to wait and tell what would happen. So we kind of know, in which categories or which ways people will have health effect. So mostly these would be of, with different temperature, rise in temperature and different rise in water level and rainfall, there would also be a lot of vector-borne diseases, especially the malaria, chikungunya, and dengue. And we are already seeing that, cities like I live in Bangalore in the southern state of Karnataka. The temperature wise, it is always to be like a hill station, like not crossing certain, say 25 degrees centigrade. But now we are even going into 40s in the time of summer. So it is also alarming, and how that affects growth of say mosquitoes, and also of course the cities are getting congested, constant influx of people coming in and settling down. So of course that is like the number one. We'll see vector-borne diseases. Then there will also be a lot of the burden on non-communicable diseases will grow up, because when people move from their known geography to another, the sources of food, the availability and affordability of we're culturally tuned in to find our kind of food. And the main aspect of finding nutritious food is also affordability. So there is also this, availability of cheap food, but full of sugar, also creating a lot of stress in our population towards diabetes, also lack of exercise, because people are constantly pressurized. There is no work-life balance, so there is also a problem. There is no how the cities are planned, lack of recreation time, lack of walkability, how our transport is designed. So these are also kind of a cumulative effect. We can see it in our non-communicable disease burden. People having more diabetes, childhood obesity, leading to adulthood obesity, and of course, cardiovascular distress and stroke and heart attack. And not to mention a lot of addiction, because also about a lot of stress in life, urban life, like smoking and alcohol. And again, the second link, I'm linking it towards mental health. That is, we have also seen how in displacement and distress situation, how we see mental health aspects. Also, this is mainly overlooked, because it's also how not much understood, or is also stigmatized in many cultures. And then heat-related distresses, because a lot of kidney functions and our eye, we observe a lot of cataracts. Like, people are also living longer, but then how we are not able to look at, maintain our eyesight. So we'll also see those kind of heat-related, impacts on our health. And then, of course, with pollution and also congestion level going up in urban dwellings, we'll also have indoor air pollution as well as low air quality. And another aspect we often ignore is water, because the availability of potable water, especially, and safe drinking water and water for hygiene, these are also very linked with health and public health in any setting for that matter, but that would also probably be scarce. So I'm also parking it under impact, And it's a very important, especially in a tropical country where we constantly have issues around hygiene. So water becomes an important factor. We can move to the next slide. So when we come to talk about health, has it moved?
Yes, we're just moving. And if we could,
Okay.
if we could speed up a little, thank you, Aruna.
How much time do I have? Sorry, I think I'm speaking also slowly, is it?
Yes, maybe if we could have maybe just maybe 6 to 7 more minutes. Perfect. Thank you.
Oh, great, great. Okay, thank you. So now I kind of set this tone, set the tone for bringing the case studies that I was mentioning, and also how urban marginals are at a loggerhead with so many issues. So I find this quote very interesting. Of course, I would like to read it, and it is on the slide. In every corner of the world, certain city dwellers suffer disproportionately from poor health, and these inequities can be traced back to differences in their social and living conditions. Understanding urban health begins with knowing which city dwellers are affected by which health issues and why. So this is important, like how I brought that history of partition, how I brought the history of religion, language, the forces, like how social cultural layers that are embedded in that story of migration or story of settlement. And then I'm bringing the discussion around justice, fairness, to see how things are not equal. Moving to the next slide, please. So that brings me to the discussion of social determinants of health. Oftentimes, of course, we understand when we talk about health, it is about an interaction with a pathogen, and it's an interaction with pathogen and how we deal with immunity or not. But oftentimes, why we do what we do, or our health outcomes are laden with social, cultural, economic aspects. So this is very beautifully done. Like I am sure people who are interested to know more can read up. But I find it very interesting in how this framework has actually captured the inequities. And they're often not the causes that meets our eyes. It is the causes of the causes. So this is kind of setting the tone for the case study. So next slide, please. I am going to talk about case studies it's all my work from different timeline and in different cities. So I'll bring tuberculosis in the story. So oftentimes we understand tuberculosis is a bacterial disease, and it is, we all, I mean, again, coming from a tropical country like India, which has high tuberculosis disease burden. I should not generalize for everyone in the session. So there is also a latent infection that many of us are infected with, but that becomes a disease only when the immunity falls because the nutritional status is poor, stress is more, or access to health. For example, I'm not able to get basic health access to know what is going wrong inside to maintain my immunity or health or manage my health. So this is also in an interesting way to understand that if in a setting where I'm saying more TB, it automatically can tell you that there is a social inequity. Of course, there is a bacteria, and bacteria can affect anybody, but that is, why it is becoming a full-fledged disease itself is a proxy measure of inequity. That's how I would like to present this talk. If you look at the timeline, it is 1998. The discussion starts at 1998, and I was a doctoral student at that time. And India, because tuberculosis control program is very old. I think globally we are probably the first country to have a full-fledged program. So there was some kind of an evaluation, and there was a need to revise it because there was an observation that people are not adhering to the treatment, and treatment is very long, minimum 6 months or maximum. It can go on looking at your recovery, looking at one's recovery. So there's a revision that happened, and India is a big country, so things happens in a phase. So I was in Delhi that time as a student, and I wanted to start with what's happening where I am, in order to understand. So the important point here, because we're talking about migration, we're talking about climate change, and now we're bringing health, and that too so dated, but it is important because the way epidemiologists understood to catch or to kind of stop or to increase adherence is a directly observed treatment. So I use the abbreviation DOTS, it's directly observed treatment, so that a person, whosoever is diagnosed, comes to the center and the health providers are at a better way to kind of administer so that that person is actually taking the medicine and not taking home and forgetting about it. Because, oftentimes we have this care-seeking behavior of not completing our treatment. But one caveat, that person has to give proper documentation for residents, because otherwise, if, for example, I'm the TB patient and I forget to show up or follow up, then the provider can kind of track me. But think of a migrant worker who is not from the city, staying somewhere, having no proper documentation, and on top of it, tuberculosis being a stigmatized disease. So asking for your landlord that I need address proof for this kind of jeopardizes my access to health, right? So I think I'll just creating this layer of how in our imagination of access to health or in our imagination of better control program, we do not include, people whose social identity is different. Oftentimes that also creates a big issue, because if I'm not able to cover for a communicable disease like tuberculosis, then the larger population is at threat. Can we go to the next slide, please?
Aruna, thank you. I think we have to start wrapping up. Sorry, so sorry.
Okay. So then I quickly, because then what I have next is a study from Bombay, and the slide, if we can have. So very quickly, so again, tuberculosis, it is the revised treatment, but we still see that the new thing has happened. The people are getting drug resistant. And when I'm talking about drug resistant, it is also a product of the system, because if I have unregulated antibiotics in the city, in the circulation, and our health systems is fragmented, who's the jeopardized one? Probably the person who's most disenfranchised. And so that is a study where we actually see so much drug resistance in the city of Bombay. And moving to the next, where I actually do ethnography, live ethnography during COVID-19 in Bangalore, to understand how that social identity and then the aspect of access to health. Of course, COVID cannot be compared with tuberculosis. COVID was an uncertain, where we also saw health-seeking behavior from a cultural point of view, but how the biases, who am I? My Muslim identity versus Hindu identity versus a Dalit identity is creating a barrier to my access in health, and how community resilient, kind of health building solidarity to access health, or also this lockdown, for example, quarantining for me or you are very different for quarantining for slum dwellers. So I'll move quickly to another study that I have done. Like, I was part of this study when I was not part of IHS. It was actually an university in Bangalore. Because the bringing home here is why urban health infrastructure is so poor. Okay, it is fragmented, but why? Where are the gaps, and how can we mitigate that? So we did a consultation, and it was actually how funny that we actually needed to do this, and COVID was happening, and we saw systems crumbling. So we somehow had a vision, or I don't know, why we had this plan. We actually put different tier cities, like metropolitan, tier 1, tier 2, different kind of cities, and understand in times of crisis how things can work. And then we kind of came up with the policy consultation and suggestions. So of course, we need to build community together. The health systems cannot be in a silo, and there has to be a give and take. There has to be evidence, and of course, the social equity lens that has to be built. I think I'm at the end of my slide presentation, and I would end with a quote from this rebel poet of he's actually a national poet of Bangladesh, but before 71 he was also part of Bengali, so it's very poignant, and I would read one line. একের অসম্মান, নিখিল মানব জাতির লজ্জা, সকলের অপমান. It means like I might think that this person is a migrant and I am humiliating or it's indignified, but it actually means that we are disrespectful to each other. Thank you. I'll stop here.
Thank you very much, Aruna, for the presentation. Much appreciated. As we're running just a little bit short of time, I would like to move immediately to our second speaker, Mr. Michael Méndez, PhD. Michael is an assistant professor of environmental planning and policy at the University of California, Irvine. He is an Andrew Carnegie Fellow and a visiting scientist at the National Center for Atmospheric Research. Michael has more than a decade of experience in public and private sectors, and his current research focuses on highlighting the disparate impacts of extreme wildfire events exacerbated by climate change on undocumented Latinx and Indigenous migrants. Michael, please. Thank you so much.
Good afternoon or good morning, depending where you're at in this world. And it's a pleasure and honor to be here today with UN Habitat to talk about these issues. And my presentation will differ slightly in terms that my research looks at that intersection of urban and rural contexts, particularly external and internal migration and displacement from climate-induced disasters. Next slide. This research agenda asks how climate-induced disasters such as heat waves, drought, and wildfire can exacerbate existing disparities for undocumented Latino and Indigenous migrants. In this approach, I explore the methods disasters influence migration patterns and interactions between people and place that limit life opportunities, facilitate movements, and impact public health. Next slide. Globally, climate change is disrupting livelihoods and exacerbating socioeconomic inequalities, leaving more people with no choice but to move. For example, migration from Mexico is influenced by multiple factors: growing economic inequality, violence, drug conflicts, and trade wars. This situation is now compounded by environmental decline and changing climatic events, particularly in the agricultural and indigenous regions of central and southern Mexico. However, when Latino and indigenous Mexican people migrate to places like California in the United States for better life opportunities, they often do not leave behind the disproportionate impact climate change will have on their bodies and their families. It often follows them. Next slide. For example, in recent fires, the economic impact of what is termed smoke taint is estimated to have cost the California wine industry around $3.7 billion. Smoke taint occurs when smoke and ash permeate the skin of grapes, which can affect the taste and smell of wine. However, too much concern is often placed on the impacts to the wine industry, but not on farm workers that are harvesting grapes during wildfire events and how their lungs are also being tainted. They are not provided with adequate occupational health and safety protections, let alone hazard pay or federal disaster funds to work in mandatory evacuation zones that are considered hazardous to the general population. And in these instances, of course, these are largely undocumented Latino and Indigenous migrants that are harvesting during these wildfire events. Next slide. While this research is based on the impacts of California is one of California's most marginalized and stigmatized populations, it has global implications. California's wildfire problems are now affecting sensitive populations around the world. For example, in 2020, smoke from multiple extreme wildfire events reached not only New York State, which is on the other side of the coast in the United States, but also Western Europe. Next slide. Given their social status, undocumented Latino and Indigenous migrants are particularly vulnerable to disasters such as wildfire and require special consideration and disaster planning. They are disproportionately affected by racial discrimination, exploitation, economic hardships, less English and Spanish proficiency, and fear deportation in their everyday lives, or what I refer to as their pre-disaster marginalized status, or the social determinants of health that we think about the last presentation. And it's important to note that disasters like extreme wildfire events only exacerbates existing inequalities, and they create this hyper form of marginalization for this population. And if you really want to tackle disaster risk reduction, it starts with the social integration of migrants before disaster strikes, including them in our social safety nets, such as healthcare, unemployment insurance, and other key benefits. Next slide. My research is done in the community engaged project with migrant rights and labor rights organizations that are at the forefront of some of these wildfire disasters. They have been living with these events for many years and are vital contributors, co-authors to this research. And we had presented this research at multiple scales at the local, state, federal, and even international levels at the International Organization for Migration, another sister agency of the UN. And we really highlight in these presentations that political choices are being made that intentionally withhold vital resources and prioritize some lives over others. Next slide. Just for context, climate change is making wildfire season longer and more severe throughout the Western United States. Moreover, 17 of the 20 largest wildfires by acreage in California have occurred since the year 2000. And Sonoma, one of our case studies, which is in Northern California, one of the premier wine regions of our country, is an epicenter for wildfire and a bastion of California's high-end wine industry, has suffered from multiple years of extreme wildfire events, have been ranked in the top 5 and 20 for the most destructive and deadly wildfires in California's history. While climate scientists expect wildfires to become more frequent and severe, it is important to explore how some people and communities are more affected by these events than others. Next slide. These numbers will likely increase according to the California 4th Climate Assessment Report, which projects the state's wildfire burn area may increase by 77% by the end of the century. While many of California's fire-prone regions are largely populated by higher income groups, they also include hundreds of thousands of low-income individuals who lack the resources to prepare or recover from fire. Many of these undocumented migrants and farm workers. Next slide. Outcomes occurring during and after wildfires have major environmental justice implications, in that certain populations, due to their socioeconomic status, must live with the disproportionate share of environmental impacts and suffer the related public health and quality of life burdens. Moreover, in our research, we investigate how human identities such as gender, class, race, indigeneity, and immigration status intersect with wildfire disasters. Next slide. Sonoma County, as I mentioned before, has been the epicenter of extreme wildfire events and environmental injustice in the state. Media outlets, governments, and scholars across the country, however, have largely focused on reports on the loss of coastal and hillside mansions and impacts to wealthy homeowners and farmers. The Sonoma fires, however, not only destroyed expensive property and crops, but also endangered the health and livelihood of thousands of undocumented migrants. Next slide. In this case study, I highlight the forms of discrimination and unsafe labor practices faced by undocumented Latino and Indigenous migrants through wildfires. As one resident of the region told me, undocumented migrants are the invisible population living and working behind the Bougainvillea curtain. They are struggling to survive in a region of wealth and prosperity. This idiom references the fast-growing evergreen vine with an explosive magenta color that adorns the gates of mansions and farms for added privacy. And we can see that on the left-hand side. Next slide. California is home to an estimated 2.6 million undocumented migrants, many of whom are farm workers or employed in service sectors such as housekeeping and landscaping. In Sonoma County, undocumented individuals are estimated to account for 8% of the population, or 38,000 people. And this is likely a low estimate because many of them do not participate in the census taking. Next slide. Governments in California in particular overlook the needs of indigenous farm workers and migrant families in developing disaster plans. Sonoma County is home to a growing indigenous Mexican population. It is estimated that over 12,000 indigenous people from Mexico live and work in Sonoma County, and this is also likely a very low estimate. They are often concentrated in labor-intensive sectors such as row crops and wine grapes. Indigenous migrants perform the increasing amount of arduous labor, which contributes to the profitability and affordability of fresh fruits, vegetables, and wine. In particular, indigenous Mexican people in Sonoma County are culturally and linguistically isolated. Many are illiterate, and some speak neither Spanish nor English, but only their native languages such as Mixteco, Triqui, Maya, Chatino, and Zapotec. It is important to note that indigenous Mexican people are not Hispanic or Latino, but indigenous. They are often homogenized with the larger Latino community in the United States. Next slide. While disaster relief efforts in Sonoma fires have largely been praised as effective, migrant workers were especially impacted by the fire due to the loss of employment, violations of occupational health and safety standards, the lack of evacuation information in their native languages, confusion about eligibility for disaster relief services, lack of unemployment and healthcare insurance, and poor infrastructure and housing in migrant communities. Undocumented migrant socioeconomic situation is usually precarious. However, the wildfire disaster intensified their already difficult situation, again, creating this hyper form of marginalization. The Sonoma fires, moreover, revealed how undocumented migrants and those with seasonal work visas require special consideration in disaster planning. These individuals are often afraid to seek help and restitution during and after a wildfire disaster because of language barriers and prohibition from assessing federal disaster assistance programs. Next slide. It is the lack of occupational health and safety standards is of key concern as intensifying wildfires collide with harvest season each year. Undocumented farm workers are shouldering the burden of protecting Sonoma's wine grapes from smoke and ash. Fine particulate matter, often known as PM 2.5, from wildfire smoke, which is this toxic mix of heavy metals and chemicals from burning structures and other objects, can be several times more harmful to human respiratory health than PM 2.5 from other sources such as car exhaust. Since 2015, in Northern California, the annual mean PM 2.5 has increased because of extreme wildfire events, and these events have overtaken as the main source of PM 2.5 exceedances in the region. The harm that wildfire smoke causes to farm workers may be greater than previously thought, further and increasing the need for additional research and new policies around this issue. Next slide. And just to give you some idea, one more slide back, yes. Just to give you a little bit ideas about the inequality that these farm workers, indigenous farm workers largely are facing, I want to read 2 quotes. The first quote is from an indigenous farm worker who told us, quote, "We all got sick, our throats closed from breathing in too much smoke, and our kids could not go to school. We had to buy masks and medicine for our throats and some goggles because my eyes were irritated when I worked." Many of these farm workers are working hours, days, if not weeks, in these extreme wildfire events. This fire in particular lasted almost 2 months. And one of the farm workers told us that they would come home and literally have black saliva. Another outdoor worker told us, quote, "I could not get to the homes where I worked because the streets were closed. 2 of the homes I worked at were destroyed. One of my friends was lost during the disaster. He had only been living in the area for 3 weeks before he died. I myself am a cancer survivor and the only one who provides for my family." So this quote really highlights this idea of the existing pre-existing health disparities and social inequalities that these individuals experience in their everyday lives. And when it collides with a climate-induced disaster, it creates this synergetic event, or what they call in the field of public health, a syndemic, where again, this idea, they experience a hyper form of marginalization and inequality. Next slide. Next slide. So just to wrap up, I know we're running short in time. Yes, I want to leave you with this research implication. The major research and policy implication of this type of research in these situations of climate-induced disasters is for disaster research and response, we need to think beyond just property values, understanding that these individuals may not necessarily always live within the footprint of the fire, which are largely wealthy homeowners and farmers, but they live adjacent to these in rural and urban contexts, and that, of course, wildfire smoke transport travels and moves across regions. And not only is work shut down and infrastructure severed within the footprint of the fire itself, but adjacent, and that the existing economies from hotel, tourism, and education are also shut down, and also affects other types of workers. And also to really understand how this population has been living with these types of inequality for many years. For example, if we look at this photo right here, it's a young children with N95 respirator masks. I think we all become desensitized to images like this because of the COVID-19 pandemic. But if you look at the date, it's from 2017. So this population has been living with these forms of inequality for many years prior to the COVID-19 pandemic. And again, these wildfires actually also took place during the COVID-19 pandemic. So this compounding of multiple types of disasters that have cascading health and social economic impacts. So thinking beyond just property values and how there's a multiplier effect or domino effect into multiple urban and rural contexts. And next slide. So to end with this idea, if you really want to tackle one slide over, tackle disaster risk reduction, it starts with the social integration of migrants before disaster, acknowledging the existing social inequalities that these individuals have, their exclusion from social safety net, and really designing policies that integrate migrant rights, labor organizations, and these indigenous and Latino immigrants before a disaster strikes. Next slide. One more. And one more. There. So these are some points about how we can legitimize local knowledge, embrace communities in disaster planning, response, or recovery, and increase civil society's organizations' capacity in disaster relief and planning efforts. I can talk a little bit more about some of the achievements these groups have done in changes to policy and social programs, but I know we're short on time. And thank you for this opportunity. One more slide over. And just like to acknowledge some of the funding that I have received to pursue this research, and also to thank the labor and migrant rights organizations that I have worked closely with. Thank you.
Thank you very much, Michael. Colleagues, now that we've heard from both Aruna and Michael and seen examples from India and Mexico, we would like to open the floor up for maybe one or two questions to our speakers.
For that, you can raise your hand.
I don't see any hands at the moment. Perhaps what we could do, I'm not sure as well, Kirsten and Christelle, perhaps we could leave Aruna and Michael's contact details if colleagues would like to reach out after the webinar as well.
There's a question in the chat.
Thank you. Sorry, I actually can't see the question.
I can read it. The events of this summer in Greece and other countries have highlighted the intersection of migrant and urban health issues, especially in regions prone to wildfires. What can we as urban planners in that case do to better embrace the preparedness and response strategies for wildfire-related health outcomes while ensuring inclusivity for migrant populations beyond policies which Michael touched on? I think it's my research. I talk about how these populations are rendered invisible in the context of public policy disaster planning because of political choices that are being made that intentionally withhold vital resources, including disaster preparedness, knowledge, and planning, and other types of materials. So it's important as urban planners, policymakers, elected officials, and other appointed officials that we make an effort to identify socially vulnerable population, particularly those that are stigmatized, such as undocumented migrants, and acknowledging that these are individuals that are within our communities, are often the most vulnerable, and ensuring that there's outreach and relationship building between government, civil society, and the organizations that represent these labor and migrant organizations, and that work is done before the next disaster strikes. So fundamentally, allocating resources and disaster preparedness and relationship building and acknowledging that this population exists within your local communities is the first effort, and try to build up that support of including them in your disaster plans, and of course, reaching out to their trusted leaders and organizations.
Thank you very much, Michael. I hope that answers the question to our colleague. Yes, perhaps what we could do as well is we could leave both Aruna and Michael's contact details, so colleagues could reach out to you in your own time as well for further discussions. And I would really like to thank both Aruna and Michael for shedding light on disparities in such different contexts. Aruna really for showing us the urban health considerations through a triple nexus lens of marginalization, migration, and climate change, and the vulnerabilities that the civilians living in the slums in urban areas face through diseases, physical or mental. And Michael for revealing the impact of wildfire, exacerbating socioeconomic and health impacts, and creating that bubble of concentrated marginalization, the syndemic you were saying, that are faced by migrants, by those undocumented and living in obscurity, and for the impacts that they face direct or indirectly through these fires as well. So thank you very much for making the time for our session today. I would actually now like to pass the floor to Kirsten for the closing poll.
Yes, thank you, Jia, for moderating our session. Before we call it a day, we, the Urban Health team, would like to check how much you took from today's learning session by a short closing poll, which will pop up on your screens. If everything worked out, you can indicate how much you took from today's learning session. Also, feel free to share your personally most interesting learning of today in the chat. And of course, if there's any urban health related topic that you'd be interested in, feel free to share that as well in our chat. Today's webinar may have been the last one for this year, but we'll resume our series next year with other interesting topics at the intersection of urban health and planning. So let me check what the results are. It's a 4.0, and that's definitely more than we had before. So congrats to the speakers. Thank you for sharing some of your insights. Everyone stay tuned, and thank you for joining today, and I'm wishing you a good rest of the day. Bye-bye.
Thank you.